And good afternoon, and welcome to Trust America's Health H1A Public Health Systems April training on our training series. I'm very happy you all joined us today, so you can learn more about how the public health sector can support older adult health and well-being. My name is Karan Phillips, and I'm joined today by my colleague Megan Wolf. The AFPHS movement would not be possible without our generous support from the John A. Hartford Foundation. Just as a reminder, please keep yourselves on mute during the presentations. Feel free to put your questions in the chat throughout our session today. There will be time for questions at the end for both of our speakers. And your feedback is very valuable to us. We kindly request that each participant take a few moments to complete an anonymous survey that will appear on your screen at the end of the training. Your insight will be shared with our evaluation team. Our partners are the New York Academy of Medicine, and this will greatly assist them and the TIFA team in enhancing future trainings. As most of you know, TIFA is a public health policy, research, and advocacy organization dedicated to optimal health for every person and individual. TIFA produces several reports annually, including Ready or Not, which focuses on emergency preparedness, which we'll be talking about today, and will also Pain in the Nation. Relatedly, related to healthy aging, we have produced several reports on several different topics, including housing, rural healthy aging, and also how the 10 essential public health services aligns with our AFPHS 6Ts framework. So for today, and for this year, I should say, our trainings are generally on various topics, and this year we're focusing on equity. We will show how equity intersects with key topics and how they all support healthy aging. Equity is the center of our 6Ts framework and central to supporting all older adults. And today's training will focus on our Ready or Not report and different highlights from that. And I'm happy to introduce our speakers for today. Our speakers are from our own TIFA team, so we're excited to have them with us today. First, we will have Rhea Bartman, who is the Director of Strategic Communications and Policy Research. And then we'll be followed by Megan Wolf, our Senior Policy Development Manager here at TIFA. So Rhea, I'm going to turn things over to you to take it away.
Thanks, Karan. Good afternoon, everyone. Thanks for your invitation to join you today. So we're going to be talking about, as Karan mentioned, we're going to be talking about TIFA's latest report, which is our Ready or Not report, which was released in March last month. This is an annual report, and what it does is it assesses our national and state level preparedness to protect health during emergencies, public health emergencies, be they weather events or infectious disease outbreaks come to mind. So it's a report that we've done for now over 20 years. And what we do is tier states into 3 performance categories based on 9 key indicators of public health readiness. You can go to the next slide, please, Karan. So this year, as we've done for the last few years, we are tiering states in 3 performance categories: a high performance, middle performance, and low performance tier. And for this year, this is based on 2023 performance. We ranked 21 states in the District of Columbia in a high performance category. So they had a high level of readiness to protect health during emergencies. 13 states in a middle performance tier and 16 states in a low performance tier. And you can see on the chart where your state fell. Let me emphasize that even those states in a high performance tier, there's still work to be done. There's certainly work to be done nationally to ensure that everyone's health is protected during an emergency and safeguarded during an emergency, and to make sure that we are ready for whatever the next emergency will be and ready across a spectrum of emergencies. And so even if you're a high performance tier, there's some things you can still do. And if you're in the low performance tier, those states certainly have more to do. It doesn't mean that they're necessarily wholly unprepared, but there's some challenges there and some more work that needs to be done. Let me give you a few examples of what the indicators, the performance measures are. We look at 9. We look at public health funding, whether it's going up or down. We look at the state's rate of adults. Well, it's actually more than adult. It's all flu vaccine, the flu vaccine rate. We look at whether the state is providing through its municipal systems clean water to every household. We look at the number of people in the state who are employed who have access to paid time off. And we look at patient safety rates in hospitals within the state. We look at whether the state has surge capacity to surge healthcare facilities during an emergency. So are they involved in a state compact for nurses, for example? Is there a plan to surge laboratory capacity during an emergency? So those are the types of things we're measuring, and these are the findings. Next slide, please. So at the national level, some of high-level findings that I'll just summarize is that most states are ready to surge healthcare capacity during an emergency. This was particularly important during COVID. They have plans to surge laboratory capacity, and they have plans to surge healthcare facility capacity too, particularly nurse compacts that allow a nurse who's licensed in a state to provide services in another state, either in person or telehealth-wise, because there's an agreement between states. So if one state has an emergency and needs more hands on deck, they're able to get that assistance through these compacts. Most residents who get their water from a municipal system have access to clean water. It's in the very high percentages, 98, 99%, so that's good. Not every household is on a municipal water system, though. If you're on a private well system, that's another measure. So we have to pay attention to that as well. Most states are accredited for either public health or emergency management or both. And that's just a sign of the state's commitment to making sure that they have the public health capacities and skills in the workforce that they need. Seasonal flu vaccination rates are low, too low. On the national average, it's 49% of adults who are vaccinated for seasonal flu. The target set by Healthy People 2030 is 70%. So we have a lot of work to do at the national level to make sure more people are vaccinated for seasonal flu. The good news here for this audience is that amongst older adults, we're hitting that goal of 70%. So that's good news there. Although I guess we'd like to see that number to be even higher for older adults. In terms of employees having access to paid time off, and you know why that's important, so they can stay home if they're sick and get well themselves, but also not spread the infection in the community. That number is in the high 40s percent-wise for most states. We'd like to see that increase. And only 25% of U.S. hospitals on average earned an A grade for patient safety. So that's an area of attention that needs to improve. Now there's some B and B plus grading, so it doesn't mean that all hospitals are failing on these numbers, but we'd like to see everyone get A grades. Jane, a question popped up and I missed it.
You want me to say something? I was just asking when I saw your report. This is, I know the report is amazing. Did you look at nursing homes? You had hospitals there?
That's not an indicator at this point. But I'd love to have a conversation with you offline about what might be a measure for nursing homes. Are you thinking specifically of flu vaccination?
Your vaccinations. Yeah, I was just thinking. Yeah.
You know, that's a question. I don't know the answer to that question. Let me check. This is CDC data, and
I'm sure they have. I can look it up, Maria. No worries to stop.
Yeah, I assume it includes nursing homes, but I'm not sure. I'm not sure. We can check though. Next slide, please. So the report, we do a special feature each year on a subset of the overall issue. And this year we looked at the impacts of extreme heat and who is at highest risk during heat waves. Obviously very topical. And what we found is that heat waves are more frequent. They're occurring at higher temperatures and of longer duration. They're occurring in places that aren't used to extreme heat and long heat waves. For instance, Washington State. I was talking to a Washington State official about this last week, and they were sharing how when Washington State had a heat wave in the summer of 2022, I believe it was, people were just not prepared because many houses in the community don't have air conditioning, and many facilities in the state just don't have air conditioning because they didn't need it before. So there were a number of deaths in Washington State during heat waves. So it's an issue in places where it wasn't an issue before. And just to drive home the seriousness, more people died due to extreme heat in 2022 than any other weather event. And that's really striking when you think of hurricanes and flooding and other kinds of weather events. Extreme heat is causing more deaths than anything else. So it's a serious issue, one that we need to pay attention to. Next slide, please. So heat is an issue for everyone at any age and within any population group can be made ill due to heat, but some population groups are at higher risk than others, and you see the list here. And what we want to talk about today is the risk for older adults. But you see that many people are at risk. People who work outdoors, people with chronic disease, pregnant people, infants and young children. So it's a really serious issue, and heat-related illness is a serious thing. Next slide, please. So what's the impact on older adults? First of all, older adults age 65 and older account for more heat-related hospitalizations than any other age group. So that's striking. Why are older adults at higher risk? It's usually due to not so much age, but medications that older people might be taking or chronic conditions that older people might have that impact their body's ability to regulate heat. So it's age factored, but also age plus other factors. And if you are an older adult who lives in an urban heat island or is dependent on public transportation to get to a grocery store or a medical appointment, if you live without air conditioning or you can't afford to use your air conditioning, those intersecting factors put you at even higher risk. So that's something that we all need to understand and prepare for. Next slide, please. So CDC recommends that all municipalities have a heat response and heat plan, one for preparing for heat waves and then how to respond during a heat wave. Many localities have them, but not every locality does, and every locality should. So the plan should anticipate what the impacts of extreme heat will be on the community. They should determine thresholds for when a heat activation plan will be put in place. They should identify at-risk populations. They should understand the community. These plans have to be crafted in such a way where they are appropriate for the community and community populations. Plans should identify partners and partnerships. That's going to be really important down at the grassroots level. Who are the partners who can help you deliver the services that will be needed and the precautions that will be needed during a heat wave? What are the roles and responsibilities? One interesting thing that I learned when I was speaking to people to write this special section was often during the midst of a heat wave, it's unclear between entities who's really in charge, who's in the lead, who's doing what. And of course, that slows the response and makes it less effective. So determining specific roles and responsibilities ahead of time is critical. And then, of course, having an evaluation process once the event is completed. Next slide, please. So what are some of the things that jurisdictions can do to guard against the health impacts during heat events? One thing is having the data, surveilling what has happened in the past, and what are the potential impacts on a population during a heat wave. So data collection, surveillance, and analyzing the data, knowing, for instance, the makeup of your community. What's the percentage of population without air conditioning, and where are those people? Where are your urban heat islands? How can your public transportation system adapt during a heat wave? Those types of issues. Communications is obviously a very important role in heat response. I'm always interested to note that when there's a snowstorm predicted, it's all over the news, and we're all alerted about snow, but we're not really as alerted when it comes to heat. And that's interesting. Heat is more dangerous than snow. Snow can be dangerous too, but I think heat is more dangerous. So it's interesting to note that we think in terms of communications when it comes to bad winter weather. We're going to have to think in terms of communications in addition to public communications, but in the workplace communications for heat waves as well. Identify what the healthcare sector needs to do and social service sector needs to do, and how entities can work together to provide services. Create neighbor outreach programs, neighbors checking on neighbors programs. Have cooling centers and have plans in place, pre-identified, pre-equipped cooling centers that can be opened immediately when during a heat wave, and communicate to folks about where are those cooling centers, how you can get there. Make sure they're in places that people are comfortable going to. Is it a local school? Is it a local church or synagogue or mosque? Is it a local community center? How can people get there? And are they comfortable being there? Water distribution, literally water, making sure people have access to cold water. Fan distribution programs. Changes to the built environment. Are jurisdictions investing in planting trees to create shade canopies? That's not going to solve anything overnight, but over time, shade canopies are important. Is there shade at public transportation stops, the bus stop? Is the bus stop shaded? Those types of things make a difference. And some jurisdictions are investing in energy programs to help people afford use of air conditioning, or help people afford window replacements to make their home so the cool can stay inside. Insulation in the home so the cool can stay inside. Those types of things, if a jurisdiction can afford to invest in those, they're very helpful. So that's what I have to set the stage. Be happy to take questions now or once, okay. And then Megan's going to go into more in depth some interesting examples and scenarios about the specifics for the older population and what some entities, some jurisdictions are doing. But happy to take questions, comments.
Priya, thank you so much. I'm so pleased that Tifa does this. You said something about heat islands. I might have missed what you meant by that.
Sure. Yeah. Thanks for asking me to explain that. A heat island is typically in an urban area. So it's usually in a city where there is little or no shade canopy. So the trees have been unfortunately knocked down, they've died, there's no shade canopy. There's a lot of asphalt, so the heat is rising up from the asphalt. There's no park. There's just, the sun just bakes down, and at night this heat rises up from the asphalt, and the community just isn't able to cool down. So that's an urban heat island.
I had a question also, Rhea. You mentioned that that there's accreditation, obviously, for public health departments, but there's also emergency management accreditation. What organization is responsible for that accreditation?
Let me look that up for you, Megan.
No worries. I know that the National Association of County and City Health Officials, NACCHO, they have a lot of great resources to support local health departments in planning for and preparing for emergencies. So I highly recommend checking out their emergency preparedness toolkit and resources while you're looking that up.
Yeah, the Emergency Management Accreditation Program is sponsored by the Emergency Management yeah, this doesn't, I'm going to say the Emergency Management Accreditation Program, but that doesn't make sense. So let me check that for you.
No worries.
Yeah, the Public Health Accreditation Board is the board that accredits for public health.
Right. Yeah, thank you. Any other questions for Rhea or comments? And so, we would really appreciate also if you all have programs and strategies that you have adopted and are implementing to address older adult health in climate emergencies and particularly extreme heat events. We'd love to hear about those. We're always looking for innovative practices, best practices. And so if there are, if there are links to your websites that you can share, we would appreciate knowing that as well. So let's keep going here in the presentation. Rhea, thank you so much for being here and sharing with us today. It's so helpful, and we're so proud of our reports that are published every year. So let's go to the next slide. So I think that what Rhea has laid the foundation for is an understanding that this is a public health issue, and we're really hoping that some of the information that we provide here today will give you all at least a starting point if you haven't already begun to adopt public health practices to protect older adults in extreme heat emergencies. We hope that we can give you some ideas and thoughts. We're going to be talking about some equity issues, and again, hope that you'll feel free to add any comments about your work in this area in the chat. As with all public health topics or areas of work, TIFA believes that older people should be considered, as many do have complex health conditions that necessitate public health attention. And I also want to put in a plug for attending to the needs of caregivers, because as we're thinking about cooling centers, as we're thinking about the opportunities to communicate, we need to be thinking about the supporting caregivers as well, because they play a huge role in the care of older people in our communities. Also, before we get too much into the rest of the slides, I do want to acknowledge that there's not been nearly enough research on the effects of extreme heat on older people living with complex chronic conditions. We hope that's beginning to change. We're starting to see a little bit more research and attention. Really grateful to institutions like the Columbia Aging Center that is really beginning to shine some light in this area. So next slide, please. So I'm going to go into a little bit more detail about some of the issues that Rhea already touched on and hopefully elaborate a little bit more. And then I'm going to provide some an example of one local health department, local health jurisdiction in Washington State that has really stepped up and responded to this area, and some links to some additional resources at the end of the presentation. And also just to let you all know that we always make the slides available to you, as well as the recording. We'll include some additional links as they are included in the chat along the way. So we know, as Ria said, we know that older adults are at a higher risk of serious health impacts during extreme heat situations for a variety of reasons. And I'm going to focus on the three kind of main categories that, when we think about the intersection of these three areas, give us this big picture of vulnerability for older adults. And these are the biophysical changes experienced by older people, socioeconomic factors, and equity-related disadvantages of despair or disparities. And we also want to be thinking about, as we're thinking about not just caregivers, but people living with Alzheimer's disease and related dementia, and to understand that these individuals may not be able to process the risk from exposure to heat the same way that non-ADRD people are. So they're not only not able to process the risk, but may not have the same understanding of messaging and may not have access to some of that messaging. So really important to think about how we communicate with people living with Alzheimer's and related dementias. Next slide, please. So we know that the subpopulation of older people is not homogeneous. So I'm 66, and we know that, you know, the people who are anywhere from 65 to 85 or 90, we have different characteristics. We have different medical conditions or not. And so we need to acknowledge that there are differences, but we also want to acknowledge that there are some changes that occur as we age. For example, many people experience decreased thirst and sweat responses, and these can be exacerbated in a very hot environment. And if you're not thirsty and you're not drinking enough water and you're not perspiring, that raises the risk of dehydration, which can then lead to further health complications. Some of the complex chronic conditions that older people, especially those over 85, may face can increase the risk of even more complications when they are overheated. And some of those conditions include conditions like diabetes and kidney disease, especially. And as Ria mentioned earlier, there are numerous medications that can alter the body's response to heat, including ACE inhibitors, beta blockers, and especially diuretics. Next slide, please. So that's one of those circles, the biophysical conditions. And then the next one is socioeconomic vulnerability. So begin to think about when all these three different areas, when they come together, the increase of vulnerability of older people to heat. So when it comes to socioeconomic issues, people living in poverty may not be able to afford air conditioning, as Ria mentioned. And in some parts of the country, air conditioning is just not a given, like the Pacific Northwest, which until recently had not experienced prolonged periods of heat that necessitated the use of air conditioning and other air cooling systems. Social isolation is another factor that can increase the risk of harm. When people live in remote areas, they may lack opportunities for communicating regularly, for being in touch with other people and engaging with other people on a regular basis. So these are situations when our faith communities, our churches and synagogues and so forth, can really provide that connection for people living in remote areas. First responders, community health workers, and others become those key contacts that we need to take advantage of and leverage those systems. And I will also say there are, just the old-fashioned phone tree can sometimes be a real lifesaver when it comes to these kinds of emergencies. We've also seen that residential care facilities, whether they are nursing homes, rehabilitation facilities, or adult day centers, have experienced increased mortality rates following disasters for a number of reasons. And these can include simply the lack of the care workers training in emergency procedures. And I think that is something that can be built into an emergency preparedness plan, is to make sure that people who are caring for other people are trained in emergency responses. The fact that there are just not enough direct care workers as well is a big risk factor. And there's a lot of confusion that often happens in emergency situations. So these factors all come together to raise the risk of for residents living in residential facilities. And so Ria also mentioned public transportation. and the transportation options that older adults may rely on a regular basis, they may not be available during emergencies. They may not have air conditioning, which will increase the risk of extreme heat. So this reduces the option to even get to a cooling center or to get to a medical appointment in case someone is suffering from a heat-related illness. Next slide, please. Okay, so we've covered the biophysical, we've covered socioeconomic, and now we're going to talk a little bit about the equity-related disparities. So race and ethnicity are well-known drivers of health disparities, and these drivers can be heightened during emergencies. For example, we talked about people living in low-income housing may not have access to air conditioning, and even if they do, maybe the air conditioning units are old, maybe they're ineffective, and maybe people can't afford to turn them on. And I also want to mention another category, another subpopulation of people who we often don't talk about when we're thinking about extreme weather, and that is people who are incarcerated. People of color are disproportionately impacted during, they are disproportionately represent the population of people who are incarcerated. And we have seen that there is just not adequate regulation of temperature control in our jails and prisons. The conditions are not good. In some states they are, but in many states they aren't. So this is a population also that may be at a higher risk for harm from heat-related events. And when we think about the immigrants in our country, particularly those with limited English proficiency, our health system is very complicated. People who have limited English proficiency are already going to have some challenges in just understanding our healthcare system. So they may not understand where to go and what to do in an emergency situation. And if we're not providing messaging and communication in their native language, that again raises the risk for greater harm for this population. I mentioned earlier the lack of research on older people and climate emergencies, and this is even more true for the LGBTQ+ community, which may also experience discrimination in the aftermath of an emergency, and that can in turn lead to a possible increased risk of homelessness and greater poverty. Some of our previous AFPHS trainings have addressed challenges in rural settings and rural areas, and this is also going to be exacerbated during weather emergencies due to the variability in access to resources and support. I think we've all become aware in the last couple of years of the closures of hospitals in rural areas. And in these geographies, where are people going to go if they're having a heat-related emergency? If there's no hospital or clinic within a 50-mile radius, it really makes it incumbent upon other systems to pick up the slack and make sure that that our older adults and residents in rural communities are attended to, that we know who they are, and that they are attended to as well. So I hope that these three kind of areas give us a picture. If you think about someone with a chronic condition who's living in a rural area, who may not have air conditioning, there's a lot of intersectionality and increased risk of vulnerability to heat-related events that we need to be aware of. Next slide, please. Just a few additional considerations that I wanted to point out. And one is people living with disabilities who may need further accommodations, particularly in a cooling center. We need to be thinking about those cooling centers and emergency shelters in general, and making sure that people living with disabilities and people with durable medical equipment can be accommodated, as well as providing space for caregivers. So it's not just the people who have, who need the shelter, who are the older people, but also their caregivers. It's really important that we accommodate them in these emergency shelters and cooling centers. I mentioned earlier, people living with dementia need additional consideration, particularly when it comes to communication, and the needs of people who are socially isolated. Who are they? How do we find out about them? How do we make sure that they are being taken care of and communicated with? And how do we get to them? So these are all really important questions. Next slide, please. So all this, I hope, points to the need for the public health sector to know and plan for the needs of older people during extreme weather events in order to protect their health. And next slide, please. Of course, you all know, if you've been attending our trainings, that we like to focus solutions around our AFPHS 6 C's framework. So the 6 C's are creating and leading change, connecting and convening, coordinating existing supports, collecting data, communication, and complementing. And so I want to go through just a few strategies that are related to our 6 C's, or kind of fall within the construct of our framework. So the first one is thinking about how can public health practitioners create and lead in this space. So public health practitioners can lead efforts to prioritize older adult health and well-being, and including older adult needs in emergency preparedness policies and plans. And I would say this is also an area where we can think about state and community health improvement processes and planning. Think about including, if emergency planning is part of your community or state improvement process, think about emergency planning, think about including older adults as part of that planning process. Public health practitioners do a really great job of connecting and convening key partners. So let's do that for emergency preparedness as well, and including partners across aging services, emergency services, and healthcare to build that coalition that can be optimized during emergency preparedness systems. And this is also where you can think about accountability, whose responsibility it is for communication, whose responsibility it is for evaluation, and so forth, and thinking about resilience and response. Public health practitioners can coordinate existing emergency preparedness supports and the tools that may already exist, and create a centralized hub for protocols, for toolkits, for resources for both older adults and caregivers and other agencies who can take the lead from public health during an emergency. Next slide, please. Public health practitioners can collect, analyze, and translate data. And I think Ria brought up some great ways to think about data and what kinds of data that we need to be collecting. But to look at your emergency systems, collect data on that to be able to identify needs and disparities among older people, and thinking about how we can use that data to better support resiliency following an emergency. Public health practitioners can communicate the heightened risks that older adults face during emergencies. So that's kind of externally to partners and to the public, but then also to make sure that messaging is culturally relevant and accessible in diverse communities in your jurisdiction. And then public health practitioners can support systems for older adults by distinguishing and addressing the additional needs of certain groups among older adults, as I mentioned, those living with Alzheimer's disease and related dementias, those with impaired mobility, or those who live in disaster-prone areas. Next slide, please. So I do want to talk specifically about the public health, the public health department, the local health jurisdiction in Seattle and King County. So in the summer of 2021, the Pacific Northwest experienced an extreme heat event during which there were 157 heat-related deaths. And this was shocking at the time for this area. And almost 70% of those deaths were among people aged 65 or older. So in response to this situation, the local health jurisdiction, Public Health Seattle and King County, created an extreme heat response plan. And I've added a link on this slide, so you will get the slide, so you'll have the link and you can go and check out their heat response plan. It outlines strategies the public health sector can use to reduce the risk of negative health outcomes from extreme heat events, many of which we've already kind of talked about here today. So next slide, please. So these strategies include a new notification and warning system. So exactly what Ria was talking about. In addition to a snow warning system, Seattle King County now has a notification and warning system for heat. Collaboration with emergency management for incident action planning. We know that public health departments are very familiar with this incident action planning for all kinds of public health emergencies. And so now this is one for heat. A development of heat health and safety guidelines that identify those lead agencies and enforcement agencies, so accountability and enforcement. And then includes communication strategies like disseminating information about where are the cooling centers, and promoting that messaging for vulnerable populations. So it's a whole plan on what the messaging is, how it's promoted, who does it, and so forth. Next slide, please. So as part of our AFPHS work, we have worked specifically with the Washington State Department of Health. We engage with 5 local health jurisdictions in partnership with their area agencies on aging in their communities to adopt practices aligned with our AFPHS 6 Cs framework. So Public Health Seattle-King County was one of those local health jurisdictions. And so they elected to focus on heat-related emergencies. So they conducted a survey of the county's senior centers to determine the senior center readiness for heat-related emergencies. And I'm going to show you the result of that survey on the next slide, but they also provided training for public health practitioners to respond to heat-related emergencies. And I believe that training also was made available to folks who worked in the AAA and who worked in the senior centers. They created emergency kits for older adults determined to have the highest need for support. Those kits included things like an extra water bottle, checklists for what they needed to have in their home and who to contact, a list of where the cooling centers are, and so forth. And we can put you in touch with the folks in Seattle-King County if you're interested in the complete list of what's in those emergency kits. It was pretty cool what they did. And then they've been able to share these resources, everything that they've developed, with other local health jurisdictions in the state to enhance the public health role in preventing harm to older adults during these emergencies. And I also wanted to mention the folks in Spokane and the local health jurisdiction in Spokane have developed a training that is, it's not completely free, but I think it's under $10 per person, for how to communicate with people living with dementia in emergencies. And so I'm hoping we're going to be able to find the link to that. We'll include it in the follow-up email that we send with the recording for this training, because it's when we first heard about this last year, we thought it was an amazing opportunity for folks to build their capacity to understand and communicate and better support a whole population living in their community. Next slide, please. So here's the 2-pager that is a summary of the Senior Center Emergency Readiness Survey that they did. I know it's hard to read. Again, you'll get the slides, but I just want to pull out a couple of the statistics here. So while 55% of the respondents, the senior center said they could act as a cooling site, 45% said maybe or no. Over 60% did not have a working generator. Almost 80% did not have enough drinking water for 10 days for their participants. And only 50% had enough space for overnight sheltering. So this provided the local health jurisdiction health department with the information they needed to help the senior centers better prepare for heat emergencies, so that they are aware now that they need more water, that they need generators, that they need to expand, and this really helps with their advocacy as well with the legislature and with their local governments, so that the local governments know what they need to do to better support the community in the face of emergencies. That I also love this as an example of how public health can partner with agencies in a community to address challenges for older people and caregivers in extreme weather emergencies. So we're very proud of our partners in Seattle-King County. Next slide, please. So I also wanted to point to some resources from our federal partners. And this is just such a small sampling of what is available. The National Advisory Committee on Seniors and Disasters is part of the Administration for Strategic Preparedness and Response, or ASPR. And they have developed this National Advisory Committee, which provides advice to the Assistant Secretary for ASPR and within the U.S. Department of Health and Human Services, as well as to the secretary. So they've come together, they think about what is needed, and they provide advice for our federal leaders who are leading these efforts. And then they also have guidance for integrating people with access and functional disabilities. So this provides information to help state and local government planners to address access and functional needs of at-risk individuals during disasters and emergencies, and includes resources on regulation, executive action, potential legislation, and examples of real-world promising practices. So again, all these links will be on the slide that you will get with the follow-up email. And then CDC also is a wealth of information. This book, this public health workbook, explains what at-risk populations are and how to estimate the number of people with access and functional needs in your community. This resource also includes information on locating at-risk populations using digital mapping or other alternatives, how to conduct surveys and focus groups, and then analyzing the data that you receive. So that is the end of our formal presentation today. So Karan, if you want to pull down the slides and we will have a discussion. And again, I don't know if I can emphasize it enough, we want to learn from you all as well. So if you are aware of other strategies and programs in your jurisdiction, if you have been implementing them, we would love to hear about them, but we're also available to answer questions. So please go ahead and if you're willing to take yourselves off of mute and let us see your video, we'd love to have your questions.
Hi, Megan.
Hey, Kina.
Hi, I'm driving, so I can't take off
Okay.
video so that I can focus on the road. But I do have one question that I may have missed in the presentation. We work with our state medical needs shelters, especially during emergency preparedness, hurricane, tornado seasons. And I just wonder with these state medical needs shelters and those emergency volunteers, if there is an opportunity for maybe a training that's already been developed or shared information that we could present to that team. Because they have been very interested in collaborating with us for our age-friendly public health work, and not to reinvent the wheel, but to just be able to maybe duplicate something that has already been shared with those emergency responders who work in those state medical needs shelters.
Yeah, I'm not aware of them, although I'm sure that probably does exist. So let us check with NACCHO. I feel like that's probably the best bet for that kind of training. And again, we'll check in with our partners and the Spokane local health jurisdiction as well to see what they have. Rhea, I don't know if you're aware of any additional training, but we'll take a look and get back to you.
Okay, great.
Great question. I don't know if anyone else on the call is aware of any of those training opportunities.
Megan, I'm just going to bring up, nursing homes were on my mind. I had just attended in Pennsylvania. They have a big network, and their topic was emergency preparedness. And of course, in their emergency preparedness, they're talking about all the same sort of things. And then they also mentioned, the reach out to public health. So it just might be something down the road that we could have, something with public health and nursing homes in how they could align, because they do table talk, they do tabletop practices, exercises, and they do 3 or 4 a year. It just might be something fun, Megan, to think about. Great,
thanks, Jane. And Morgan, I see that you have put something in the chat. You want to come off mute and describe the resources and tools that you all have developed at the Montana Public Health Institute?
Sure. So we just developed a guide to support populations with access and functional needs, which include older adults, and we broadened that definition to include like historically marginalized groups as well. We definitely tailored it to the emergency preparedness language, so it's geared towards FEP staff, but it has a lot of action ideas and different resources and tools that staff can kind of just plug and play into their work. to start thinking about building that inclusivity and accessibility. So yeah.
Very helpful. Thank you, Morgan. That sounds great. Anyone else? All right, well, thank you all for your attention today. As I said, we will be sending out a link to the recording as well as the slides and link to other resources. Karan, if you want to bring the slides back up, and I will turn it over to you to close us out.
Thank you, Megan, and thank you everyone for joining us this afternoon, or yeah, it's afternoon most places. And again, as Megan said, we will send out the slides and the recording within the next few business days. I wanted to prepare you all for next month. Next month is Older Americans Month, and we will be focusing on the theme around connectedness. And again, related to the Older Americans Month theme. So the training is on May 16th. So you can register for that on our website. It is up and ready for you. And if you are pursuing a champion designation, please log in your attendance with this training. I see lots of familiar names, so I know a lot of you are very close, if not already champions on our training right now. If you're viewing this as a recording, please pause at this point and navigate to the website listed, or use the QR code to record that you've attended our training this afternoon. And with that, thank you all for joining us today.
Many thanks. And thank you, Ria. Very, very much appreciate your time and expertise. Thank you so much for sharing.
Sure thing. Thank you.